So I think the challenge is going to be is, can we make MRI better? This is so often the question we say, oh, does screening work or not? Does PSA screening work? And I'm like, well, it depends on how you screen. Can we make PSA screening better? And does MRI work or not? So, well, how can we make MRI better? And I would say, let's work on MRI. Let's see if we can actually improve it to the level at which it has a high and consistent negative predictive value, and then it could be used as part of routine care. The other idea that's come up at papers presented at this meeting is the idea of risk stratification before MRI. And the rough idea is this. Okay, MRI is pretty good, but it's not perfect. So if you have a low risk, a positive MRI, you'll still be low risk. It's not going to shift that probability very much. If you have a very high risk of cancer and your MRI comes out negative, well, that's probably, you should still probably go and do the biopsy. It's probably the MRI has just missed the tumor. But if you're somewhere in the middle, maybe that's where MRI is helpful. You're sort of intermediate risk. We don't know whether we should go to biopsy or not. Maybe let's look at the MRI at that point. So that's a sort of novel idea. It was recommended by the authors of the European Urology meta-analysis. We've seen a couple of papers on that here at the AUA 2017 meeting, and I think that's going to be over the next couple of years, is can we define exactly who we mean by being at intermediate risk and define exactly how useful MRI is in those men.